to place him in terms of medical research. Not only is Dr. Parker become one of my friends, colleagues, and main discussants in the research I'm busy with at the moment, but he is an international public health consultant, and he's based in San Diego. So it's 6:30 a.m. in San Diego, which makes me appreciate this even more. Thank you, Warren, for getting up so early for us. He has worked in public health and in pandemic health response in more than 20 countries since the early 1990s. He has been closely involved in the COVID-19 response at country level, including South Africa, and with international organizations, including the United Nations. He is a senior research fellow at the Center for Communication, Media and Society at UKZN, and is a fellow of the Balsali School of International Affairs in Waterloo in Canada. He's going to talk to us today about where we can expand our research portfolios beyond the quantitative medical research only to answer some of the more subtle questions that we can't answer just with p-values. So Warren, I'm going to hand over to you. And once again, thank you very much for speaking to us this morning, in your case, or this afternoon for us. Thank you. Handing over to you.
Great, thanks so much, Colleen. I'm just going to share my screen. Good, all right, yeah, it's great to be able to be connecting with UKZN and with all of you on this topic. But what I'm going to be sharing is essentially my experiences in qualitative research to respond to questions around health. And then hopefully that'll prompt you to think about how you could apply it in your own context. So what I'm going to do is cover a few key points about the differences between quantitative and qualitative research. Colleen's given a good background about where I'm coming from, but I'll just embellish that a bit, I guess. And then we'll have a look at types of qualitative research, methods of qualitative research, and very quick summary. And then a few examples and lessons learned through the research I've done over the years, applying qualitative research, mostly in a preventive health context, but you'll see when we come to those examples that it's really about the insights you're going to get from qualitative research that are vital for medical practice and health. Qualitative research in your context, so that's going to be looking at how you think you could apply it in your context, obviously very different context for many of you. But this is really just a think piece to prompt thinking. And then that will lead into the Q&A at the end. So it's not a long presentation in terms of number of slides, they're just 12, but the examples I'll chat about in detail. So let's have a look at what sets quantitative and qualitative research apart. So firstly, quantitative, as we know, is numerical, and qualitative is largely textual. And what I mean by textual is it could be narratives, it could be text, it could be anything that describes something, any way of describing something that's not really numerical. So quantitative, again, also measures quantities versus qualitative assessing qualities, the types of qualities, the inherent qualities of the way people see the world. Quantitative research is concerned with objective measures, so you try and reduce everything you can to a number. It can even be behaviors or attitudes or various forms of thinking, but it's still numerical. We're counting the occurrences, versus qualitative, where we're looking at subjective things, not countable necessarily. Quantitative, again, is closed-ended, so if you're talking about questionnaires, it's questionnaires that have got discrete categories and statements attached to them, versus open-ended. Qualitative can go in many different directions. A piece of qualitative text is not directly comparable to another one. You have to analyze and see how to distill the comparisons. Quantitative gives you less depth, but more range. So you're going to have lots and lots of cases, whereas qualitative focuses on a few cases, but digs deeply into them. Validity and reliability of quantitative research is related to your system of measurement. So if you have a really good research design and really good measures, you're going to end up with a good quantitative study, whereas qualitative, you really have to be working from a theoretical framework. You need to be understanding how meaning is made and think about how to interpret that, and then use analytic skills to interpret it. So it's a different way of analyzing as well. And it is also a skill that you have to develop. Both are generalizable. So often people feel that qualitative research isn't generalizable because you don't have the numbers. But as we'll see in some of these examples, with the right type of analysis and interpretation, you can apply the learnings at very high level. So many of the examples here that I'll share with you here relate to work that I've done with small groups of people in isolated communities, and that's translated into national level campaigns and so on. So where am I coming from? As Colleen mentioned in the beginning, this is some of my background. Social science. My discipline is cultural and media studies, which incorporates lots of multiple social science disciplines. So you can come from an angle of anthropology, psychology, sociology, etc. All of this blends into this discipline, and it's got a lot to do with how one applies meaning or makes meaning in social circumstances. My postgraduate focus has been on critical health, so really looking at health from a critical perspective, trying to understand and question many of the assumptions that underlie our health. 30 years in public health, mainly focused on preventive health, including epidemics, diseases, nutrition, maternal health, and violence. And then I've also worked in more than 20 countries doing both quantitative and qualitative studies, and often mixed method studies to guide policy strategies and programs. So let's have a look at some types of qualitative research. This is not an exhaustive list, but ethnography is one type. This is one that you might typically think about when one's doing anthropology, applying an anthropological lens. So an anthropologist would immerse themselves in a community, they would observe and interact, and would be able to draw conclusions about that community or around his research questions. Historical research, looking at the past to try and understand the present or future. Phenomenology, so it's really describing and analyzing experiences or opinions or perspectives to understand an issue or concern. This is quite a common approach to qualitative research. Narrative research, which is gathering stories and other data from people and then using those stories to understand processes. Another is grounded theory. So what you would do is gather data across a broad, across whatever area of focus you want, and then use that to test a theory or develop a theory. So a theory might be that people who are fearful respond in a certain way to COVID-19, if you like. Some would rush to vaccines, others would be hesitant, and so forth. So one would think about what causes that difference. Case study research, so this is looking at a particular event or context or a situation or experience or a person and describing what you see there. So all of these can be applied in your context as well, irrespective of the field, but some of them tend to be used more commonly than others. So the types of methods you would use to undertake qualitative research would be interviews, focus groups, observations, notes, recordings, or images. So that would be more ethnographic. Storytelling, so getting people to narrate stories of their lives or their perspectives. Interactive workshops, so you can do qualitative research by interacting with groups of people. Participatory inquiry, this is a kind of extension of that, how you engage with people. Action research is another methodology that I'm mostly going to be focusing on today. And that really involves using research to inquire about certain circumstances and then look for solutions with the participants. Analysis of text, diaries, logs, and narratives. So these would be diaries that people have kept, or logs of events, or stories about events in their lives. Analysis of images. So this would be looking at, you can actually analyze the way an image looks, a photograph looks, and unpack its meaning. Content analysis, so this would be looking at text and so on. And then in essence, what we're trying to do is focus on how people make meaning of their circumstances and how people interact. And in the health context is how that learning is applied to health. So that inquiry is applied to understanding or improving health. So I'm going to go and have a look now at some examples. So this was an early example. This was actually very long ago, in the early 1990s, in South Africa. At that point, we had an emerging HIV epidemic. So HIV at that stage was a very low prevalence, but potentially high risk, a high risk for an epidemic linked to the global pandemic, and potentially high risk for young people. So the problem at the time was that the way health communication was approached was a very top-down model. The health department said, these are the types of things we want people to do in response to HIV, and they hired ad agencies to do it. Advertising agencies in that context applied an advertising model, so based on commercial advertising, appealing to people to behave in certain ways, but often decontextualized from their circumstances. So the main concerns really were that there was a top-down approach, that it was focused on biomedical models of thinking. It was contextually disconnected, so disconnected from people's context of the young people, and culturally disconnected because advertising agencies don't really represent or understand fully people on the ground, particularly young people at that point. So my research questions at that point were, is a bottom-up process possible? And can the findings from a bottom-up process be applied to health communication? Through that process, I developed an action research methodology that I've called action media that's been used widely since then. And I'll give you an example of what came out of that particular early experience. And that was this poster. So what we see here is a poster with a South African flag on a condom, the slogan "Viva Condoms." And this came out of discussions with young people at the time. And it's got all sorts of meaning embedded in it. So the flag at that point was a new flag in South Africa. So that was seen as a sign of hope and an important part of responding to HIV at the time. So that was linked to a prevention method that young people could use. And then Viva Condoms connected to the slogan that was used at the time, where Viva was part of the political struggle as a word and as a way of expressing a particular thing. So these things connected very well with youth, and it was derived from how they saw and made meaning around HIV prevention. Of course, this didn't necessarily connect well with the powers that be. So in fact, there was a very negative response from the state president's office at the time, because this was seen as a violation of the South African flag. So you can see that there are tensions between how people on the ground see things and how people in the upper echelons might see things. And you can also see that this type of image wouldn't necessarily be generated by people who, in the sort of stratosphere of health communication or health, it requires a bottom-up type of approach. So despite the controversy, that poster actually got produced by the Department of Health as part of a national campaign. You can see it here up against a poster board with someone distributing condoms, and then also pasted up all over as part of the national campaign. So that went from a small group of people discussing how to deal with HIV in their context into a national arena and a national program. And it was used over several years. So you can see here that we just had a small group of people who I worked with in a type of participatory qualitative approach, translating what I'd learned there into something that applied nationally. There's an article on Action Media and its development and thinking over there, so you can refer to that if you like. Then here's another one from China. So this context was in the early 2000s, and my task was to look at the risk of HIV transmission through needle use by people who are using heroin. So at that stage in China, and still is, highly illegal. This group is hard to reach, and they lack trust in authorities. So the approach again was participatory research. I worked with drug users in rehab centers, and we had a look at problems and solutions and ways of communicating around this issue. So one of the first things we did was work with this group of people and try and understand a day in the life of people who are using heroin. And you can't really see it there, but in the top left corner, it depicts someone staying at home. They wake up, they then move on to get to try and access heroin, but they need money, so they go to a shopping center and either steal money from people, or some of the women work as sex workers and so on. They get the money, they get the drug, they take the drug, they go back home, and that was the cycle. So that was one insight, just to get a sense of what things looked like. But what was really interesting is when we started talking about HIV as a health risk, the main interest of that group of people was actually how to help a friend who'd overdosed. So they weren't really that interested in HIV as a health risk. They were more interested in the more immediate health risks, which were to do with overdosing on heroin and how they could help a friend. So we included that in the communication. We also included information on how to avoid HIV transmission through needle use. But the group was also interested in more of a social role as well. So they were interested in preventing others from becoming hooked on heroin, because they saw it as ultimately a negative thing. So one of the things we did was also look at some images and concepts. And this is one of the concepts that came out. It's an image that shows a single injection or single syringe on one side of the scale and thousands on another. And the slogan was, one injection is too much, 1,000 is never enough. So it was a way of them symbolizing that once you try heroin, you end up getting hooked on heroin very easily, and that has a negative consequence. And there were a whole lot of other images and concepts that came out of this interaction. But if we think about drug users as potentially selfish and self-focused people, it's interesting to see here through this research that they were actually concerned about the immediate environment, people in their immediate social circle, and also society as a whole. So a different perspective emerged. And we can see here our health interest in HIV was weighed against these other interests and concerns they had. Similarly, in Uganda, a similar kind of thing came out. So this is in the last 10 years or so. Fisher folk in Uganda exposed to HIV. So this is related to sex work and mobility. People move around on the Lake Victoria. They're fishermen, they're boat operators, they're fish sellers, they're equipment sellers, they're sex workers, they're dock workers. So there's a lot of exposure to HIV in that context. And the task here was to try and understand how HIV risk could be reduced. So here's some fisher folk on Lake Victoria working on nets. So the findings here were also quite interesting, that we came in with an HIV agenda, but people were fatalistic. And they were fatalistic because there was actually a very tangible and high risk of drowning when you're out on the lake, either whether you're fishing or you're taking a boat across the lake. There were risks of these boats tipping over and people drowning. So that was an immediate risk. The HIV risks were seen as less immediate. HIV communication in that context was disconnected from the local culture. So it wasn't meaningful, it wasn't particularly of interest. But what we did find is proverbs and humor are more meaningful. So people when we talked about how would you like to communicate about HIV, people defer to proverbs. So here's an example of a proverb. I'm not going to read the Swahili, but the proverb means manhood is not determined by having many sexual partners. So it's a way of using a cultural format and applying it to an HIV context. This is another one. So this is one of the posters, and this was really around how to either use a condom or avoid having sex, avoid avoid taking part in sex work. And the slogan here is "Be alert, cowards live longer." And as you can see, there's a kind of wry humor embedded in that. That's unusual in health communication, because it's very difficult to develop something like this conceptually on a top-down basis. So it's kind of laughing at the situation, but at the same time creating a message around being cautious around sex. This is another one, violence against women. This was in South Africa. This was a multi-year project also in the last 10 years. The research took place in Khayelitsha in Cape Town, or near Cape Town, and Wentworth, which is a township near Durban. The initial assumptions on this project were that we wanted to prevent violence against women, and it appeared that social norms drove violence or underpinned violence. So, for example, it's okay to beat your partner because it's a sign of love. That was one of the things that kind of seemed to exist in a normative space, or a man should have sex whenever he wants, and so on. So these kinds of concepts were seen as social norms. So we went out to understand how people understood them and what they thought about them. And we actually found that there was very low support for these kinds of statements. So people didn't actually believe this and didn't support this. They were actually concerned about violence against women. So the question became, so what's driving it then? And what we found was that what was driving it was that people just didn't know how to act, or they didn't feel inclined to act. There wasn't a norm to take action. So even if they came across instances of violence against women, they just didn't respond. They didn't know how to respond. They just felt uncomfortable. So we looked at changing the norm of inaction in response to violence against women to a norm of action. And this took place over a number of years. We developed a model where we trained people in communities to just focus on this thing. So a social mobilization model where people would develop small groups, set up small groups, and then talk about violence against women in their immediate context, and then look at actions that could be taken, and then people would begin sharing actions. What we did then was every time someone had come up with a particular action that they could take, for example, if the neighbors if there was a violent dispute between neighbors, husband and wife or something like that, people would develop a set of scenarios or actions that they could undertake, and actually use these as examples for what had worked or hadn't worked, and then we would share these. And there were a lot of highly nuanced examples. So, for example, one of the groups set up a fun run as a way of getting couples to appreciate each other, and so on. So these stories help drive this process of action because people could see examples. And what that ultimately ended up as was people declaring violence-free zones in particular areas in their communities. So that became the outcome of that project. And again, if we come back to it, it was our assumption was wrong in the beginning. It wasn't the social norms that we thought were driving violence against women, it was the lack of action. So we took that over. Another example, malaria in Malawi. So here, malaria is obviously a big concern in Malawi. They have programs that deal with malaria very well. Typically household spraying, distribution of mosquito nets, education, and so on. So although these interventions are quite well implemented and seem to be working well, malaria incidence is still high. So we went in to try and understand what was going on there. So we established that awareness and concern for malaria was high. People were worried about getting malaria themselves. They were particularly worried about their children getting malaria. There was a good distribution and uptake of mosquito nets. People mostly used mosquito nets overnight. And they were also aware of teams coming through to do household spraying and so forth. So the question became, so why is malaria incidence still high? So one of the things we found was bed bug infestations led to people sleeping outside. So people said, well, we use the nets, but we have a bed bug infestation in our house or in this community. And to avoid getting bitten by the bed bugs, people get off their beds and go and sleep outside because the bed bugs are in the mattresses. They also saw bed bugs crawling up the mosquito net. So there was a sense that the mosquito nets were actually also contributing to the bed bug problem. So that discouraged people from using nets consistently, even though they might start out the night under a net. Another issue that was raised was people were doing agricultural work and they would come back in the early evening and have their meals outside and so forth. And that's an excellent opportunity for malaria mosquitoes to bite people because they're active in that period. So that was the second part of it. And then the third was that there was quite a lot of stagnant water around in the communities, but no one was cleaning it up because they felt that you have these external programs that come around and sort out the malaria problem. So it's not a responsibility of any person in a community. So our intervention then began to focus on, well, if you're going to try and prevent malaria, you need to deal with the bed bug problem in this particular context. And it may have also been quite widespread in other communities. And that can be dealt with. You can eradicate bed bugs and then reduce the chance of people sleeping outside. People also talked about access to insect repellent, which interestingly is not part of malaria campaigns in African settings mostly. So we looked into that. And then community health action committees in the communities could actually take on the responsibility of clearing up stagnant water rather than waiting for some external agency to deal with it. So these are just some examples that came out of that study. And that's also written up in the Malawi Medical Journal for your reference. So that's, I'm hoping that we have a lot of discussion around this. So those are just some of the examples. I can refer to more examples, but let's think about qualitative research in your context. So I know some people working in the medical faculty are looking at genetic conditions. So one question might be, how do parents explain genetic conditions to their children? We're not going to find an understanding of this in quantitative research. It really needs a qualitative inquiry. And there's an example of an article on that, a reference there. One might also be interested in non-adherence to chronic medications. Again, very difficult to understand this quantitatively. You really need to go in qualitatively. Risk factors perpetuating chronic conditions. So although people have chronic conditions, they tend to continue to expose themselves to risk. We're not going to find out what underpins that through quantitative research. We need a qualitative approach. Factors underpinning alcohol abuse. So why do people abuse alcohol and in turn suffer the consequences of many negative health circumstances? Again, requires some kind of qualitative research. Stigma and discrimination in healthcare settings. So why do certain people avoid health services and attributed to stigma and discrimination by healthcare workers or other patients and so on? We need qualitative research to understand that. COVID-19 vaccination is a topical issue at the moment. Some people are keen to have vaccines, other people are hesitant. How are we going to understand that? Qualitative research again. So we'll move on then to Q&A and invite any comments on the presentation as well.
Thank you so much, Warren. And then if you can put your video on, that would be great. I see we had a hand up very early on, and I asked Abraham to hold back. Abraham, would you like to pose your question? And then afterwards, anybody can just speak up. We're a small enough group, you don't have to put a hand up. Abraham, are you still with us? Okay, it looks like Abraham's hand went down. I know that there are some people, just looking at the attendance here, that are busy with some aspects of qualitative research. Abraham, are you back with us? Okay. Let me just go through. I remember Bilkish is here, and she was very interested last week. And Dr. Makatini is here too. Bilkish, would you like to comment and speak specifically to your work in geriatrics?
Thank you, Colleen. And thank you very much for the presentation. Unfortunately, I'm in my car, but I can speak as long as you can hear me. So we're doing mainly quantitative research, but we're doing research in the field of aging. And as our speaker has just said, there's some questions that we can't answer. And we're looking at two particular situations. One is about aging. I mean, what do people think about aging? What is healthy aging? What are the cultural concepts of aging? It is something that people, more educated people or professional people take to heart. But what does the ordinary person feel about aging? What are the advantages? What are the disadvantages? What are the problems? And one of the things that we're battling with right now is, what is healthy aging? What does it mean if they say somebody is aging well? What is not aging well? And for us also, then the problem is how to find those questions to ask people. So that's the one area that we're working with, and that we're trying to get something. And then last week when we had the presentation, we're used to working with large numbers, as you know, and our study that we are going to be doing is going to involve over 1,000 people, the quantitative aspect, and people over the age of 40 or 55. And then the question is, how many do we choose to talk about it? Last week we spoke about it, and we said, you don't need that many people, and each individual's opinion counts. You don't need to be adjudicating anything. You just need to understand what people are saying. So that was the one aspect. And the second aspect that we wanted to do quantitative research on was, qualitative, was we're looking at the prevalence of knee and hip osteoarthritis. And we know that many people do not want to go and have surgery. And we want to know why people do not want to go and have surgery. What are the barriers? What do they think about surgery? So that's what we thought would also be a good qualitative question.
Warren, would you like to respond to that? I think particularly the sample size, and then reiterating what Bilkish has said, some of those questions cannot be answered by quantitative work.
Great, yeah, sure. I think one of the biggest challenges for people who are familiar with quantitative research, exploring qualitative research as a methodology, is a deference to how many people do you need, and what size should the sample be, and how many people should be involved in various subunits of research. So how many people should be in focus groups, and how many focus groups should you have, or how many interviews should you do? So you certainly pointed out that one needs very small numbers, or much, much lower numbers relative to your quantitative study. To give you an example, all of the examples I've used here have involved me working with a group of 15 or 15 to 20 people at the most, sometimes 10 or 12, in a workshop type scenario where we spend a day or 2 days or 3 days together. But what you can see that's come out of that is something that's relevant at a national level. Each one of those inquiries resulted in a national level contribution to national level thinking on health. So when you work back, it's just 14 people. A lot of what was important was the process. So obviously it's not practical to do that type of methodology for every research question, and not necessarily appropriate either. But it's really a question of digging deeply and what kinds of methods are you going to use. So I would say one of the things that also happens in qualitative research is people tend to gravitate, particularly quantitative people with a quantitative background or inclination, tend to gravitate towards having, let's say, 20 or 30 focus groups or 20 or 30 interviews. Now, each of those has got to be transcribed, and then each of those has got to be analyzed. And practically speaking, it's very difficult to analyze more than 15 or 16 just 15 or 16 data points. So one needs to think about it from that point of view. But you can also have very few. It depends on the question and where you want to apply the knowledge. But the more time you can spend with people, the more depth you can engage in terms of this research question itself, the less important it is to have many, many data points. I found that once you get over 15 or 16, you end up having a reiteration of the same points. So it depends. And again, it's the research question, it's a budget issue. These types of numbers would apply to research that's going to go probably at national level. Whereas if you're looking at a smaller inquiry, something local, you could have 4 or 5 focus groups or supported by 4 or 5 interviews or observations or whatever it might be, and actually get to your answer quite quickly. The main thing with qualitative as well is you can gather the data quite quickly. It's not too complex. The complexity is in devoting time to the analysis. So one also needs to make that balance work. Think about spending more time analyzing the data and less time gathering the data.
Thank you. So can I just ask another question? So please forgive me. I really don't, I'm trying to learn, and by next year I'm going to know much more. When would you decide to do a one-on-one interview? And when would you decide to do a focus group?
Okay, so there's a lot to talk about here, but in quick summary, a focus group is going to give you a kind of general picture from the perspective of quite a few people. And typically the types of things you're going to talk about there are attitudes or examples or perspectives, that kind of thing. But people generally would be discouraged from speaking about themselves and encouraged to speak about their circumstances in context. So a focus group is going to give you more sort of community or social level insight into something. But you can't go and ask private questions to someone in a focus group because there are other people around. So the interview would really be to dig deeper on the more personal issues where people might be required to reveal how they think about something or feel about something that's not something they would talk about in front of others. So that's one way of distinguishing between the two. Another way people use interviews is the notion of working with stakeholders and key informants. So that's also at another level. So it would be people higher up the chain of inquiry, for example, speaking to other healthcare workers about this issue and so on, or having them share their experiences and so forth. So those are other ways as well. I'm hoping that gives you some direction.
Yeah, thank you very much. That's great.
Thanks, Bilkish. And I'm really so happy, Bilkish, that you are pursuing this research, because I've been trying to get the foot in the door to get students to expand their research questions to include qualitative work. And I have been planning talks for the next 2 years, and we have planned, scattered through those 2 years, more focused workshops on particular types of research. So we will talk about how to set up a good survey questionnaire as opposed to a focus group discussion, etc. So we will be looking at more detail going forward. There were 3 hands up in this order: Yoliswa, Nelly, and Richard. Yoliswa, I see your hand has gone down. Is that because it was timed down? Or have you not wanted to ask a question? And Elliot, I see your hand up, so I'm going to address those questions in that order. Yoliswa?
No, Prof has already asked some of the stuff that I wanted to ask, because I'll be doing the research with her on the perception of aging. But I also just wanted to know, so with the methods, can you just do one method, or you have to do like interviews, focus group, or it just depends? Like, do you have
I mean, it's really around the question. So if your question relates to trying to understand the perspectives of people, let's say a group of people experiencing a similar phenomenon who could share some general ideas about it, the focus groups would be great. And you could just try, you could think about what might come out of that. And many studies just use focus groups. I don't actually use focus groups or interviews much in the research I do, because I use this participatory method that kind of combines people working in groups and people working in small groups or at individual level. So it's a kind of hybrid methodology, but it really is related to the research question. So it really comes back to deeper personalized insights would be interviews, and slightly more general circumstantial types of perspectives from focus groups. And then you could also do other things. You could ask people to keep diaries, or you could ask people to take notes of certain things and come back and feedback on them, either on an individual or group basis. So there's a lot one could do. Essentially, it's really around the inquiry, but the focus groups are useful because they give you kind of a good general picture, some good general insights, and sometimes that's sufficient for your inquiry. And if not, one adds to it. But obviously you want to plan ahead and say, I'm going to do either this method or both methods or 3 methods.
Warren, I know that you do come to South Africa at least once a year. It might be a good idea for us to plan ahead and for you to run a workshop on your method at the university here, because there will obviously be no textbooks on it. So maybe that's something we could line up for the students. Nelly,
sure, yeah, I'd be happy to do that. Yeah,
great. Nelly, would you like to pose your question?
Thank you so much, and good afternoon, Prof, and everybody. I'm Nelly Shapley. I'm actually one of your PhD students on health sciences. And my background and my niche is actually on medical sociology. And then I was listening, and also I'm supervising because I'm a lecturer. As I was listening, I was kind of like wondering and thinking some of the issues, especially the example that was given on aging. Some you might know in terms of numbers, how many people would view a certain idea in a certain way. But in order to understand what influences those views, it takes on issues of culture, the social setting, health promotion ideas that are going on in the community and so forth. So for me, I have seen that in order to manage well, to come out with a realizable effort of information in your research, it's when you go for mixed methods. I would want to hear more on your idea on mixed methods approach, because you could have combine both qualitative and quantitative methodologies into one study, but you will have a cluster of methods, instruments that you will be using on ground. Let's say maybe you start your topic or your question or your study purely qualitative. you just people are just answering on specific things that you are asking. But then at the same time, you would need to explain to understand why certain behaviors are happening the way they're happening. Like, why would people shun having vaccine and things like that? So you would want to understand the social context of those people. And in order for you to say what approach then at the end of the day, because for me, it's always to say applied research. What is it that I come out with it in order to transform the situation for the better? So I'll just give one example just to a little bit. I remember in one study that we're busy with on COVID vaccine in the rural communities in the Eastern Cape. And one of the things that has come out in that is the fact that there is a local term for vaccination, which is different from what is expected in terms of health promotion ideas that I expressed. So the local term means prevention. And for people to understand that, to say, if you have taken a vaccine, it means you are completely immune from COVID infection. And then they couldn't understand now when you have you have to do the same things that are done by people who have not taken the vaccine. So for them, that they couldn't reconcile the fact that it's not prevention, it's actually management and so forth. So it means now, in terms of the health promotion ideas and health promotion expressions that you would have for the community, you need to upgrade yourself to something that the people are actually knowledgeable of and something that speaks to them in explaining what is going on and so forth. Why would you be infected? Why would you be at risk when you have taken the vaccine? So those are the things that actually are the reasons why people are resisting, especially saying, okay, it means that we are guinea pigs. So what is being done is actually to experiment on us. So how do you address that situation for you to have an outcome of a healthy society? So what I have been seeing is a mixed methods approach, and I would want to hear more on that, how you've handled that one, or what is your advice, Prof, on the issue of mixed methods approach, especially when it comes to clinical and social studies. Thank you.
Sure, yeah, I can speak to that. I've done many studies where we've had quantitative surveys and qualitative research in combination. Broadly speaking, the quantitative surveys give you a sort of general picture of the prevalence of a particular phenomenon or something like that. So let's take the HIV surveys. You would find out how many people used a condom at last sex, or how many people had sexual partners in the last year or whatever. But it doesn't tell you about the why of those things, the rationale underpinning those things. And it also doesn't tell you why not. So the qualitative research then would be designed around answering those questions. So a simple connection is really that the purpose of the qualitative is to deepen understanding of the quantitative. But that tends to be in some ways quite a rigid approach. So for example, you've predetermined what you're going to be looking at quantitatively, and then you roll it out qualitatively to try and match or deepen understanding around the quantitative questions. But in many instances, the real advantage of the qualitative research, as you've seen, is to have an open-ended type of insight into something. So all of the examples I gave, our assumptions weren't in alignment necessarily with what we found on the ground. So if we take the Chinese drug users, for example, you would think that people who used heroin are selfish, self-interested, and really focused on themselves and anti-society. And when we unpack it, we find they're interested in saving the lives of their friends, and they're interested in discouraging use of heroin at a societal level. So our assumptions are constantly questioned. In many instances in my research around health, people have very different opinions of what health is. For a start, how is health conceptualized? What is seen as good health? What is seen as a causal relationship? And as in the example you've seen, how do we use what we know to apply it to a new phenomenon? So how do we use what you know about vaccines to apply to COVID vaccines and so forth? So one really needs to dig into this. A lot of the method that I've been using has been focused on trying to come to terms with that. So firstly, how people make meaning around an issue, and then how they craft solutions around the issue. So these would be deeply embedded in cultural and contextual scenarios. But the key thing is this open-ended type of approach. So the quantitative is going to give you some of the answer. You can embellish it with qualitative, but one also wants to go a bit further and have this open-ended opportunity as well. And quite often, qualitative might contradict the quantitative. I can give you another example. I did some research. I was actually going to include it in the examples here, but I thought I'd keep it shorter. But we were doing a study on condom use, choice of condoms. So we were looking at if people had a choice of 3 different kinds of condom, which would they select as a preference? And we were working with groups of men, and they received condoms regularly, and then we would assess. And obviously there was a quantitative process counting which ones people gravitated towards and why and so forth. But we also went into HIV risk, and one of the questions was, did you use a condom at last sex? So you can get a whole lot of statistics around that. But when we did the qualitative research, a few of the men said, well, sure, I used a condom at last sex, but how many rounds are you referring to? And so what was happening was people use a condom the first time they had sex the previous night, but then they would have sex 3 or 4 times during the course of that evening, and they didn't use a condom then. So it's also about how the meaning of things is constructed. So we would see, did you use a condom at last sex as being a good question, with quite a finite set of answers, either yes or no. But when we looked at it qualitatively, the question was actually made redundant by what was actually happening. People were having sex multiple times, and that was defined as last sex. So we can see how these things unfold. I don't know if it got that closer to your answer, but at least a few examples.
Yes, you've actually really, even with the last example, because I was going to do a follow-up question to say, have you ever experienced a conflict between if you're using both methods at the same time, where the information or the data that you collect kind of yields different explanations and so forth. But you've just given me that example already. So thank you. Just the last one, a follow-up one, Prof, if it's okay. A follow-up one is
just quickly, because we've got other questions.
Could you also speak a little bit more loudly? For some reason, I can't seem to get my volume up here.
Am I better now?
Yes.
Okay. Just a last one. I have seen that sometimes some people would actually combine in a questionnaire both open and close-ended questions and so forth, in order to cover the part that is qualitative with the open-ended questions. And what is your take on that, and how would you define that instrument?
So yeah, I think it's useful. We also quite often, in many of the studies I've done, have an open-ended response, and you can go back and then you classify those and so forth. But it still doesn't get you, I suppose you could say that qualitative digs into reasons why, or how people make meaning, versus the quantitative is still restricted to units of analysis. So even if you have an open-ended question, which I think is good, at least it opens up the opportunity that the items that you've selected there as responses are not necessarily complete. But you're going to get a few more insights with the open-ended quantitative question, but you're not going to get down to what you'll find out in qualitative, because you're still stuck in your one's assumptions, if you like. So it's useful, but again, mixed methods is obviously a better way to go if you've got the resources to do it.
Thank you, Prof.
Thank you very much. Just a quick example of mixed method. My PhD was a mixed method in the early 2000s. I had 273 questionnaires, and I got one set of results, and then I did 12 case studies, and there were lots of contradictions. And being a PhD, I had a major panic attack because the results weren't coming out the same. But that actually did show something quite substantial in terms of what my research questions were. Richard, I'm going to let you ask your question. Go ahead.
Okay, thanks, Colleen, and thank you very much, Warren, for a great talk. It's not a question, it's actually just a bit of commentary. What we're hearing from some of our audience is something that we hear all the time. What method must I use? As though there's some sort of magic button you can push and out comes the right method. And the other thing is, and what size sample must I have? Similarly, as though there's a button you can push and out comes the right answer. The point I want to make is that, in fact, the more I look at qualitative, constructivist, interpretivist research, the more I see the similarities with the qualitative, positivist research that I'm used to. There's far more in common that separates them. And the first thing is that the answer to both of those questions is entirely dependent on what question you're asking. And the major problem with so many of our students is they don't actually phrase their question precisely, so they don't know what it is they're looking for. For example, with the quantitative, they'll say, I want to study the effect of air pollution on school performance. Must I use a case control study or must I use a cohort study? The answer is phrase your question, and then the answer to that question will become clear. What exactly is the sort of answer that you're striving to find? And then you'll find that one method is better for that answer, for that question than is another. Secondly, you'll frequently find that a number of possible methods are okay. But you've got to know your methods. You've got to study them. You've got to read about them. You've got to read papers that people have written using those different methods, and you'll get a feel, for which one is going to answer the sort of questions you have in mind. But it all starts with a question. And on the qualitative side, well, you gave an example about asking people in a group, about their sexuality. I was just thinking, what about a very sensitive topic like affirmative action? What sort of result will you get if you asked a mixed group of, okay, this is South Africa, Black people, colored people, white people, and Indian people, what they think about affirmative action? Now, there will be so much political correctness and not wanting to look stupid and cause offense. You're going to get one particular type. If, on the other hand, you ask people individually, you might actually get closer to the truth of what they think. If you ask them in focus groups that are restricted to a particular race, I'm sure you get very interesting, different information. They would encourage each other probably to move to a sort of common understanding of how one group sees affirmative action versus another. So again, it's knowing carefully what you're looking for will determine what sort of method you should use and what sort of group you should use. And then in terms of the numbers, what I always say to people is just ask yourself the question. If I might draw my conclusions after studying 5 people or 10 people or 15 people, do I really think I will be misleading everybody? And if the answer is no, I really believe now that the answer has emerged from my people. I'm justified in sharing it, then that's okay. If you think, well, I really do believe that if I ask a 6th or 7th or 8th person, my views might change, well, then that number is not big enough. In qualitative, we can apply a principle to that, which is the principle of saturation. When you're done, things are going to change. In quantitative, we can do a power study and say that you're not entitled to share your results until you've reached statistical significance. But it's exactly the same concept. Statistical significance means that you think there's a less than 5% chance that you're actually misleading anybody by talking about a particular finding or relationship. Qualitative is not quite so easy to quantify it like that, but you can still come to a point where you believe that you're not misleading anybody by sharing that particular result. So that really is the way I see it. And as I see, there's such strong parallels between what you're trying to achieve in the two types of research. And the pitfalls are exactly the same. Trying to select a method when you don't really know what your question is that you're asking. I always use the example of our students who say, I ask the research question, they say, it's about pollution. Well, that's not a question. Okay. What's your research question? It's about affirmative action. It's not a research question. You've got to know the question. And then you can find the method that will answer it. And the second thing is You cannot choose methods in either system if you haven't read about a range of methods and tried to understand them and their strengths and their weaknesses, and read examples where they've been used, so that you actually have a feel for what will answer your question or not answer it. So I hope that's actually added, to the debate rather than subtracting from it. But once again, thank you very much for your excellent contribution this afternoon.
Elliot, we will get to your question. I just want to ask Warren if you'd like to respond to that.
Yes, no, thanks. Both excellent points. I so often get asked to review research protocols and end up seeing that people have just chosen methods based on, if you're going to do qualitative, you have focus groups and you have interviews and you have this, that, and the other thing. And quantitative, the survey looks like this with so many respondents. It does certainly come back to what is the question and look for the most efficient methods of answering that question and noting what's going to be required from you at various points in the research. So as I mentioned earlier, qualitative, you need to spend more time on the analysis, whereas the data collection is quite quick. In quantitative, you're going to design something that may require quite a bit of complexity and time to gather the data, but your research approach with the software you can use and so forth simplifies that. But it really does come back to what is the question. And then just referring to some of the previous questions, it's really about how open-ended or close-ended do you want to be. So if you're looking at people's response to vaccines, for example, you actually may need to go all the way back into how they understand health, how spirituality or culture or other aspects of people's belief systems might influence how they think about something, or you're going to go closer to the question related to the vaccines themselves and so forth. But thanks for those points. It really helped a lot. Also, the one about knowing the research methods very well.
Elliot, I'm going to let you ask your question. Go ahead.
Thank you so much for the inspiring presentation. I wonder if my question will make sense, but I'll just ask. How can I use qualitative research to explore possible strategies to bring about integration between groups with different perspectives?
Sorry, I missed the last part of your question, if you wouldn't mind repeating it.
And Elliot, also just talk about a bit of your background so that Warren understands your research, the fact that you're looking at traditional medicine as well as Western medicine. Give him some of that background.
Yes, my project, my question is, what are the possible strategies to integrate traditional healer-based care into contemporary management of common surgical conditions? So here, my intention is to bring about, help using research, bring about the integration of the two systems, healthcare systems. So my question is, how can I use qualitative research to explore the possible strategies to bring these two groups with different perspectives?
Okay, great. So yeah, I think, one possible method you could consider is case studies. It sounds like you have some people who fall into the categories of interest, and you have a circumstance, the translation between this traditional concepts and the surgical concepts. So one could potentially take 4 or 5 of those cases, and dig into them in depth. So you would use a range of methods in the sense that you would be not just conducting one interview with someone or observing one situation with someone, but you would do it over time. So the case study method is a kind of repetitive qualitative approach where you would take a sequence of circumstances and time and study it over that period, or in this instance, you could study the patients you're working with over a period of time and conduct perhaps multiple interviews in different scenarios or situations, and then have a look at their perspectives in relation to each of those circumstances, and then bring it together with a case study involving another patient and so forth. So that would give you a set of information. You could also bring a few people together who in a similar circumstance and conduct a small group discussion with them. You could have two people together and do a kind of group interview, things like that. So there are lots of opportunities there. But the key point I want to get across is often focus groups and interviews are sort of one-off events. You have one interaction with someone and then it's over and that's your data. The type of research I've described here, this participatory action research approach, we typically spend 2 to 3 days with people on an ongoing basis with a group of people. Sometimes they break out into small group discussions and so forth. So it's also an iterative process. It's not just one inquiry, it's a sequence where we would start at the general picture of how people understand health, then start leading into HIV, and then start leading into HIV prevention, if you like, would be one scenario over a sequence of discussions and time. So it sounds to me like your study lends itself to some kind of sequential gathering of qualitative data.
Thanks.
Thanks. Thank you so much, Warren, for getting up so early to do this presentation and for agreeing to do it with us and for agreeing to give us a workshop on your methodologies when you come to South Africa. And as I said, Chats is also on this call. We've been looking at 2 years worth of these workshops, and we're going to go into more depth on different approaches. And I would really like to invite you again to talk to and be on some of the panels as well, discussing the research methodologies. So Warren, thank you so much for your time. I'm sure everybody all delegates have gone beyond the 1 hour. It's been really well enjoyed. And the recording, I believe, will be on YouTube. Kurt, can you tell the students where the recording will be available from? Kurt, are you still with us? It looks like Kurt has left us. Now, Kurt is the technician who will be dealing with these. You will see that he did leave the link for the YouTube presentation in the chat. So I will leave the meeting on for a minute or so that you can take the link down. And next week, I think Professor Heft is going to be speaking, and he's going to be talking about how to present your data, looking at tables and figures. So everybody have a good week, and we'll see you back here, same time, same place next week. Bye-bye, everybody.
Thanks so much, everyone. Bye-bye.
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 Bye, thank you.
For those of you still online, I have retyped it down there for you. I'll give you a minute to take it, then I'm going to close the meeting. Have you all got it now? Okay, I'm going to assume that.
Yes, Prof. Yes, Prof. Thank
Okay,
you so
good.
much.
Good. Thank you, everybody. See you next week. Bye-bye.